mainly polymorphs. Appearance turbid, because you now have a lot of inflammatory cells getting into the CSF. With viral agents, which we also refer to as aseptic meningitis, aseptic in the sense that when you look at the CSF, it looks normal to just slightly turbid. You don't have an overtly turbid fluid like you have with bacterial meningitis. So it's like, well, there's an infective process, but it's not septic. It's not producing pus. Okay, that's the idea. Again, you have elevated white blood cells. Here, lymphocytes or polymorph may predominate, but with time, lymphocytes will predominate over polymorphs. Do you need to memorize the numbers? No, I'll keep repeating this. Please don't bother your heads with the number of cells. Just know that the number of cells is elevated. Initially, you may have a mixed lymphocyte polymorph picture, but eventually you're going to have mainly lymphocytic cells at the end of the day. A gram stain, a bacterial culture will be negative because these are viral agents. The protein is slightly elevated, not as elevated as what you have with bacterial meningitis, but albeit above what you have in normal CSF. Now, the glucose is normal or slightly reduced. With chronic meningitis, which may occur with agents such as Mycobacterium tuberculosis, which can occur with fungal agents, which can occur when you have poorly treated acute bacterial meningitis, the CSF may appear clear or slightly turbid. The white cell count is elevated. You can have a mixed picture of lymphocytes with polymorphs. And then when you gram stain, it's going to be negative because Mycobacterium tuberculosis cannot be stained using the gram staining technique. You learned that in your POD lab, right? If you perform ASB stain, Zell-Nelson stain, you may see some organisms, but it's usually low yield. You may perform India ink test. India ink test is specific for cryptococcal fungal agents. And you can see roundish yeast cells with a halo because the capsule does not take up the stain. I think you also did this, the negative staining during your POD lab. So you can also do this to, sort of make a diagnosis, tentative diagnosis. Protein content is high, and glucose level is low. Now let's discuss specific bacterial agents, starting with Neisseria meningitidis. Neisseria meningitidis, from the laboratory perspective, are gram-negative diplococcus. You know what that means. These organisms will stain pinkish or red, and they appear to be in pairs. So that's why we say diplococcus. These organisms can be carried asymptomatically by up to 20 population. You can have encapsulated or unencapsulated strains. Now, the encapsulated strains are the pathogenic ones. Those without capsules do not cause meningitis. They don't cause invasive infections. Nearly all invasive Neisseria meningitidis strains are encapsulated. So you have the polysaccharide capsules. And apart from that, you have these capsules can help in serogrouping because they are antigenic. So you can, serogroup the different organisms. 6 serogroups are associated with human infections often. The serogroups are A, B, C, W135, X, and Y. Serogroups B, C, and Y are prevalent in developed countries, while serogroups A, W135 are prevalent as agents of meningitis in developing countries. Serogroup X is reported in North America, Europe, Australia, and West Africa. So this has a relative restricted distribution. The organism is capable of causing epidemics because you can have spread from one person to another through droplet transmission. So when you have conditions that favors or promotes overcrowding, the spread of these agents, particularly in those who are colonized, is higher. So they can pass it on to other non-colonized individuals. And conditions that can lead to overcrowding include being in the military barracks, being on campuses when we talk about students, we have shared facilities and things like that. Infection starts acutely, and with little intervention, fatality rate is as high as 9 to 12%. Now, clinical and laboratory features of Neisseria meningitis infection. If you collect the CSF, a direct gram smear may show the organisms, and like I said, they are negative diplococci, as indicated by the arrow. This infection may also be complicated with meningococcemia, or meningococcemia may lead to meningitis. So it's a two-way thing. You may have invasion from a colonized patient into the bloodstream, and then from there to the CNS, resulting in meningitis. Or at times, it could be a CNS infection right from the beginning, and then you now have dissemination into the bloodstream. So when you have that, we refer to that as meningococcemia, and it may manifest as hemorrhagic, non-blanching skin rashes, as shown in the second picture here. Now, it's important to note the non-blanching aspect or feature of the rash due to meningococcemia, because the skin rash may resemble that of the Rocky Mountain spotted fever, the Rmsf rash. And if you have a patient with meningitis in a region where Rmsf is endemic, you need to quickly make up your mind what you're dealing with, because with Neisseria meningitis, you know the infection can be deadly. With Rmsf rash, when the rashes are just appearing, they are blanching. So when you press down on these rashes, they white out. That's what we mean by blanching. So that's very important for you to note. Now, the infection may also be complicated by bleeding into the adrenal glands. That is the Waterhouse-Friderichsen syndrome, resulting in adrenal insufficiency. You may also have the patient presenting with multiple organ failure. With Streptococcus agalactiae, it is a group B strep. It is found colonizing the genital and gastrointestinal tracts of humans. A newborn can acquire infection perinatally, because about 1 in 4 pregnant women have been shown to carry the organism in their birth canal. Otitis media is a risk factor in children, and diabetes mellitus, particularly poorly controlled, is a risk factor in adults. There is associated high mortality rate. In the lab, a gram stain will show you that you are dealing with gram-positive cocci in chains, short chains. These organisms are catalase negative. This helps you to differentiate them from Staph aureus, and they are CAM test positive. CAM test will help you to differentiate this organism from Strep pyogenes, which is also a beta hemolytic strep. A CAM test is positive when you have this arrowhead area of enhanced hemolysis, when the organism is streaked on a plate that has a Staph aureus streak. Listeria Monocytogenes is a motile gram-positive, catalase-positive, rod-shaped, facultative, intracellular organism. Transmission to human is through ingestion of contaminated food, especially raw milk products. High-risk group for infection include the immunocompromised patient, the elderly, pregnant women, and the newborn. In terms of laboratory features, the organism is catalase positive, gram-positive. It exhibits what we call the tumbling motility. It's beta hemolytic with a narrow zone on blood agar, and you have to incubate at a low temperature. With strep pneumoniae, I won't go too much into this because I believe you're going to discuss this in the lab. With Haemophilus, again, I won't go too much into this. It's self-explanatory, and you're going to discuss this further in the laboratory. So what is the approach to management? In acute meningitis, you know you have an emergency on your hands. So you have to collect your specimens quickly, and you have to start empirical antibiotics. So based on the patient's age, we already have an idea of likely organisms that could be involved. So empirical therapy will tell you the likely antibiotics these agents are going to respond to in your own practice area. Now, if you're unable to obtain CSF, take other specimens such as blood. Remember, we said blood can assist us because we know in the pathogenic process, the organisms may access the CNS through the bloodstream. Then you can start empirical antibiotics. The choice of empirical therapy that you're going to use will depend on the suspected pathogen. Suspected pathogen is based on the age of the patient, associated factors. If you have other predisposing factors, you should take this into consideration. For example, if your patient had a shunt inserted and came down with meningitis, you know that is iatrogenic. You are likely dealing with E. coli or Klebsiella, and they are likely to be multi-drug resistant because these are hospital-acquired agents. Now, you should also choose based on the local antibiotic susceptibility pattern. How can you prevent infection? Vaccines, chemoprophylaxis for close contacts of patients with meningococcal meningitis, using agents such as rifampicin, ceftriaxone, and ciprofloxacin at times may also be used. Now, with the vaccines, the strategy is this. With meningococcal vaccines, you have different vaccines that are active against different strains. So you have the conjugate vaccine, which will immunize against ACY and W135. Then you have the meningitis C conjugate vaccine. Then you have the new vaccine for serogroup B that is undergoing test and approval process. So far for serogroup X, we don't have any vaccine. Meningococcal vaccine is given as part of routine childhood immunization in Saudi Arabia. Meningitis C conjugate vaccine is provided as part of routine childhood immunization in the UK. And it's also provided for young adults between the ages of 20 to 24 and first-year university or college students. Vaccine is recommended for travelers to countries with epidemic meningitis, and it is compulsory for people that are going for Hajj, but not for Umrah, as I was told. There has been a spectacular reduction in Haemophilus influenza meningitis because of the use of the vaccine. Pneumococcal vaccine can be administered to the chronically ill and the elderly above 65 years and from 65 years and above. It's useful in reducing the overall incidence of pneumococcal infections, and it plays a role in the prevention of meningitis. Its role in the prevention of meningitis is yet undetermined. Any questions?
Good
Any
morning, Doctor.
questions?
Yes,
Yes.
you mentioned in the first few slides about the symptoms, a blotchy rash. What is a blotchy rash?
The rash, okay. Okay, so what is the question?
It's not in this one. It's in the first symptoms slide, the general looks of a patient with meningitis.
Did you take note of the slide number?
Uh,
Okay, I'll keep going back. When I get there, just let me know.
Okay.
Here?
Yes, here, yeah.
Yes, what is the question?
Under skin, you said spots or rash, blotchy. What is blotchy?
Blotchy means you have like colored spots. Okay. The skin, when you look at the skin as a uniform color, but when you have a blotchy skin, it's like you have some areas that will be hyperemic, some areas that will look normal, okay? So you have that kind of pattern.
Okay.
Okay?
Thank you. Yeah.
Clear?
Yes.
Yes. Any other question?
Doctor, yes.
Yes.
About
Please, can you speak up?
about the stereotype.
The serotypes. Yes.
Yes. Do we need to know about them? Stereotype.
Yes, it's very important because it's part of the epidemiology.
Okay. The next question is about the blanching.
Yes, blanching. Yes.
Can you explain it if you don't mind?
You want me to go over the explanation?
Yeah. What's the difference between others, the blanching and other spots?
Okay. What I said was that Rocky Mountain spotted fever can also present clinically like that picture I showed you, okay, with that hemorrhagic rash. If you are practicing in a region where both Neisseria meningitidis and Rocky Mountain spotted fever are endemic, you cannot differentiate clinically by just looking at the rash because they look the same. So when you palpate the rash and you press down gently, and you can get a whitish area, that is blanching. That is, you press on that reddish spot, okay? And then the area whites out, like you press the blood out of it, something like that. That is what happens with Rocky Mountain spotted fever in the early stages. The rashes, when you press down on them, they will blanch out. However, with Neisseria meningitidis, it doesn't occur at all. So we say they are non-blanching skin rashes. Clear?
Yes, thank you so much, Doctor.
You're welcome. Any other questions? So thank you guys. Have a nice day.